I'll bring up the slides. Am I good to do that?
Good morning, everyone. I'm going to go ahead and get everything started while they're getting their slides and everything set. I just want to say thanks for joining us this morning. And you may have heard in the introduction with Dr. Weaver, and that we are doing this with no learning lab this year, no vendor area, but we have lots of presentations. And we have all those linked through the presentation list in the agenda that's on the website. And you click on those to get to your each one of these individually. So I know this is the first one outside of the opening one we had. So every time you'll go ahead and leave the current one, go and to start up a new one with your next selection. Also, you are automatically being muted, so if you please type in the chat any questions you may have, and we'll relay those to both Robert and Jared. And so thank you very much. And let me go ahead and let you remind you we're here for the opioid vulnerability assessment across Indiana presentation by Robert and Jared. Robert Gottlieb serves as the GIS data analyst for the Indiana Department of Health, Office of Data and Analytics. He develops maps, spatial analysis, vulnerability assessments, and applications for partners throughout the department and outside partners. He recently assumed GIS coordinator responsibilities at IDOH, and I know I'm very happy about that. Robert has worked at IDOH for over 5 years. He graduated from Cornell University with a Bachelor's of Science degree in Atmospheric Science in 2009, the University of Oklahoma with a Master's in Science degree in Meteorology in 2011, and the University of South Carolina with a Master's of Science degree in Geography in 2015. Jared Sawyer is currently working as a research analyst for NORC at University of Chicago. At the University of Chicago NORC, Jared conducts mixed methods and evaluations and needs assessments for government agencies and foundations. In 2020, Jared graduated from Tufts University with a Master's of Public Health in Biostatistics and in Epidemiology, where he focused on state level and national opioid vulnerability analyses. In 2019, Jared received a Bachelor's of Arts in International Relations and a Bachelor's of Science in Biology from Tufts University. Welcome you too, and thank you very much for participating. Robert, would you like to start?
Yes, thank you for the introduction. So the way this is going to work is I'm going to start at the beginning talking about some background and previous work that was done prior to this vulnerability assessment. Jared will talk about the analysis and how this particular project was done, and then I'm going to wrap up with it for what it means to us going forward. So to start with the health department's mission and vision. Our mission to promote, protect, and improve the health and safety of all Hoosiers. Our vision: every Hoosier reaches optimal health regardless of where they live, learn, work, or play. And I hope by the end of this presentation, you'll see how this opioid vulnerability assessment plays into our mission and vision. So starting off with a national picture of the national drug overdose pattern, we've seen, especially starting about 2015, a big increase in deaths and emergency department hospital visits from related to drugs. Looking nationally specifically, a lot of this increase has come from synthetic opioids. This line across the front here, you can see this big increase. So these drugs that are listed here, they can be in pill form. They can also be injected. So we'll talk about the implications of injection and how that relates to opioids and the spread of other diseases in a few slides. So this is a national picture showing this increase. And then actually this slide here, the information here will change very shortly. It says 2020 data for Indiana are not finalized yet, but actually yesterday I got some data that I'll be publishing to another application, hopefully later today after watching the GIS Day talks today. So we'll have some updates with the finalized 2020 statistics very soon, and actually some preliminary data from the first half of 2021 we're looking to show very shortly. We'll be updating that. And nationally, we see in 2020 associated with the COVID-19 pandemic, there's been an increase in deaths due to opioid use. Nationally, about 30%. So this data that we'll be updating for 2020 for Indiana specifically will also be showing an increase. But this product from our Stats Explorer website has shown also this increase in opioid overdose death rates, again, starting especially around 2015, going up. And this, y-axis is there leaves a lot of room here, and I'll show why in a moment. But this is our state average. Talking about over 1,000 deaths due to opioid overdose each year in the state. So we've seen it go up to 2017, and then a bit of fluctuation between 2018 and 2019. So again, when this is updated, it'll show an increase for 2020. So now for the similar look, red again, the state average, but these blue and gray points and lines wanted to show that these are some of our county rates. This solid blue line, this is a rate, again, rate per 100,000 population, not the count. These are our population weighted rates. So in the blue, we have Wayne County, in the gray, we have Fayette County. So the gray points are for counties where the count is less than 20. So these are unstable rates. So we symbolize those with a different color. But the idea here is showing that, we have a state average that's increasing, but also some counties have rates that are much higher than the state average. So just wanting to get that point across. So we were looking at overdose related deaths. These are non-fatal emergency department visits involving opioids. So this comes from a dashboard. This is actually what I'm planning to update. This is one piece of that dashboard, a little screenshot. So I'll be updating this with 2020 data soon, and again, showing an increase for 2020. So getting that point across again. For the ED visits, we had more of a decrease since 2017, but again, that'll be popping up again for the 2020 data. So I'm just getting across the idea across this is an issue that affects a lot of people, thousands of people across the state, either from the direct impacts of overdose or the effect that it has upon communities at large. So we've looked at these state totals, these state rates. Now we have a map of that non-fatal emergency department visit rates. So this is also a Stats Explorer product. Also want to mention I'll have links to the resources, these maps at the end of the slides as well. So if you're interested in links, that's where all those will be. So looking at variation across the state, showing this by quintiles of highest rates. We have a few areas that are of contiguous counties that are sort of grouped together, some in the east central part of the state. You see some in the northern part of the state, some in the southern part of the state along the Ohio River or nearby, and then also Marion County and some of the metro as well, or some of the counties in this highest quintile for the 2019 data. So a bit more background, we've shown the overall increase in these overdose rates, but something that also drew a lot of attention to opioid use and associated risks was the Scott County HIV outbreak, which took place from 2014 to 2015. And Scott County is down here, one of the counties in the higher rate for this particular map, and we'll show some more examples. That's where Scott County is, a rural county. So mentioned that in many cases these overdoses come from the use of drugs that are injected. And that can also include practices like people using dirty needles, sharing needles. And with that, there's not only a risk of overdose, but there is a risk of spreading disease. And there was a lot of attention because there were approximately 200 cases of HIV in Scott County amongst people who were, almost all of them were injecting an opioid known as oxymorphone, also known by a brand name as Opana. So something that can also be used as a pain reliever, but can also be injected at other times. So there are these HIV cases, and most of the people who were infected with HIV also were co-infected with hepatitis C. So this drew a lot of attention to this issue of this concentrated outbreak. This drew a lot of attention. So one thing that the CDC did is they wanted to look at a community-wide level. Where's the risk in other parts of the country for the spread of hepatitis C and HIV? So they wanted to do a national assessment of what's the vulnerability, what's the risk of this happening in other places, because we definitely don't want to see it happen again. So looking very broadly, community level, they released this study in 2016, and I'll start to get into how that was done. Before that, wanted to show another map. This is similar to hepatitis C map. So some similar patterns. Some of the same counties highlighted that were for overdose rates as well. Scott County's down here, it shows up a high rate still in 2019, but it's a much lower rate than it was associated with this outbreak and in the couple of years afterwards. So the rate has come down. So this is a look at the hepatitis C rates, and then in addition, these counties with highlighted borders have different types of service. So in the orange are counties that have syringe service programs. So these offer a variety of resources to people who are using injection drugs, including providing clean needles, so that if they are using these needles, at least they are not risking getting infected with HIV or hepatitis C or other diseases. And then there are also resources like naloxone for reducing overdoses if that happens, and then other resources and trainings available to who need help with this condition. So there are those resources. I also want to mention, so after the Scott County outbreak, eventually there was a state law that allows local governments, counties, to decide to set up these syringe service programs. So we have a few of them in the state. We see in red a county, Lawrence County, where a syringe service program existed, and then the government decided to discontinue the program. And actually this map I made last year, it's also going to need to be updated technically at the start of the year, because Scott County, which had the first syringe service program, they have also decided to discontinue the program starting at the beginning of 2022. So that is a vote that took place. Again, these are local decisions. There are also many counties in the yellow that have harm reduction services that don't involve the syringe service program, but other resources, like I mentioned, trainings, other types of resources that can help people. And the goal here is harm reduction. So we recognize that drug use will happen. It does happen at a high rate, but the idea is to use evidence-based strategies to help reduce the harm, reduce the risk of infection from other diseases, reduce the risk of overdose if people are using injection drugs. So getting back to that Van Handel study, that CDC study, how do we go about looking at this community-wide risk assessment or vulnerability assessment? And it starts with social determinants of health. You saw the keynote with Dr. Weaver. We also talked about this for looking at COVID response. So talking not just about what individuals do, there are community-wide factors that influence health outcomes for people, how healthy is a community as a whole. These can include poverty, are conditions affecting people of different races and ethnicity differently? Are they exposed to racism that interferes with getting care or resources? In general, do people have access to medical care? Are there facilities available? If there are facilities available, do they have the capacity to treat them? Do people have the health insurance to pay for that cost of care? Do people have access to a vehicle to get to those resources, those facilities, the education level, and many more that we'll talk about in some of the other assessments. So going about these assessments, again, similar to what was discussed in the keynote, you could look at something like the Social Vulnerability Index created by CDC, which has like 15 or so of these different variables. And we're talking about getting an overall score for an area like a county or a census tract. So, a lot of this data comes from the census or the American Community Survey. And then we also have data that we can look at locally on where are these different medical facilities located, and then also data on what are the health outcomes, like showing like the overdose rates, hepatitis C rates, HIV rates, so on and so forth. So we want to create a general tool for decision makers and stakeholders to look at. It's definitely not the end all be all, say, hey, this county was high, you have to do X, Y, and Z. It's just something to get them started, but really it's up to local decision makers. They know their communities best, they know what to do, but it's a tool to get conversations started, I see. So it's just one of many tools available to decision makers, definitely not meant to replace anything else that they're doing, but just to put some things in perspective and combine some different data sources than having them all spread out one at a time. So that Van Handel et al. Study from the CDC, they did a lot of complex numerical modeling, which I'm not going to get into. But on the right, these are the variables that they found to be most predictive of hepatitis C infection, which they were using as a proxy for the rate of injection drug use. So that potential for spreading disease. So they made a list of the top 5% of counties across the entire country. And they identified 10 counties in the state of Indiana. And I'll put these on a map in a couple slides. But you can see Scott County at the time was at the top. So again, this was done pretty much right after this outbreak in Scott County. So it was not surprising that they were at the top of this list as well. And you can see other counties listed, the ones identified in Indiana. These were all rural counties, most of them in the southeastern part of the state, so also nearby Scott County. And like I said, I'll show those on a map shortly. So we came at this from the hepatitis perspective at the State Department of Health, not too long after I started here. And they said, hey, this study is really interesting. Can you also create a vulnerability assessment that uses some more Indiana specific data and dig into things a little deeper, using some data sets that the CDC wouldn't have had at a national scale, so we could add a little more detail in certain respects. So we used a combination of looking at variables that the CDC had included in their study and found to be most useful. And then we added in more of that capacity data, so having more detailed data and up-to-date data on where are all these different types of facilities that people in the state can go to, and then connecting that to outcomes. Where are these social determinants of health and capacity variables related to outcomes? So what's most connected to the deaths from drug poisoning, the ED visits, and substance abuse treatment episodes, for example. So the math I used was a bit simpler. It was more similar to the CDC, basically, more similar to the CDC's social vulnerability index, where basically I was taking a lot of standard deviations of all these different variables at county rates and seeing what was most closely associated, you know, accounting for variables that were highly correlated, so not wanting to have those overlap too much, but basically using this model of input plus capacity equals outcomes and creating a model through that. So when we combine what I did in 2017 or so, I was working on it using data for up to 2016 and compare that to the CDC study, we find some similarities and some differences. So I was looking at the top quintile, the top 20% of counties, which comes out to 19 counties in the state. So I was looking at more counties or identifying more just based on my setup. So in the dark blue, these are the counties that were identified as the highest vulnerability in both studies, which includes Scott County and 2 adjacent counties. In the lighter blue are counties that only the study that I worked on identified. So there's some surrounding Monroe County. There's some more farther to the north and east central part of the state. And then ones in gold were ones that the CDC assessment identified, but what I worked on did not. So, you know, these were studies done at different times using some different data with slightly different focuses. So it's not surprising that they don't totally overlap, but it's interesting. So that's what, so getting up to that point, we had done this assessment, and the CDC and the Council of State and Territorial Epidemiologists were also interested in helping other states do their own assessments. So they reached out to every state and wound up funding 41 of them, along with the District of Columbia, to conduct more of these assessments for their own states. And they also brought in people from Tufts University to provide technical assistance. And so we heard from them and in Indiana, and we said, well, we had just done a vulnerability assessment, so we don't think we needed another one. But then after they had worked on this initial grant program, they came back to the states that had not applied. And by that time, some more time had passed. What I had worked on had become more out of date, and we started thinking more about other ways that, you know, started thinking about taking another look at this. So we said, okay, let's do it. So now I'm going to turn it over to Jared to talk about how we worked on the study.
Thanks so much for that lovely introduction and context, Robert, as well as the lovely segue. I'm going to start by introducing some of our methods and then dive into some of our initial results. Beginning with our data sources, it was important for us to try and only use publicly available data, and this was super feasible due to the wealth of information that's on the in.gov data hub, as well as the Indiana Department of Health Stats Explorer, of which there's a screenshot in the bottom right there. In particular, we use the County Opioid Profile tab, but there's a wealth of other data and information there. From that tab, we were able to get information on opioid-involved overdose deaths, emergency department visits, chronic HCV cases, opioid use disorder services, including naloxone providers and syringe service programs, as well as opioid-related arrest data. In addition to that, we also took some data from some national level data sets, such as CDC's Exponent, which had opioid prescription rates, SAMHSA's treatment locator, which had opioid use disorder services and let us get a more holistic picture of all the services in the state. And we also pulled some social determinants of health variables from the American Community Survey to include in our vulnerability assessment. Robert, do you mind going to the next slide? Thanks so much. Once we had pulled down all of our publicly available data and merged it all together to create a county level data set, we then did what most GISers do first, is set up our Indiana county level boundary shapefile, all done in ArcGIS Desktop 10.7.1, and began to do some preliminary descriptive thematic assessments of all the variables and data we just collected to get a lay of the land and begin to analyze some themes. An example of this is on the right here, looking at fatal overdose rates involving any opioid in 2017. We were able to identify some initial trends, as you can see on this map, of just overdose death rates. There tends to be, and there seems to be some clustering in the east central area of Indiana, but we would proceed with the vulnerability assessment to begin to elucidate some of these themes. Robert, next slide. One of the things we had to consider for this, in particular, this vulnerability assessment was which indicators to include in our study due to the wealth of data that was available. And we did this in two parts. The first of which was to pre-select some core indicators informed by the Van Handel study and the IDOH 2016 report that had previously been conducted. And using this, we pre-selected a priori 5 core indicators that we knew we wanted to include in our assessment. These 5 core indicators were opioid-related emergency department visits, opioid-related arrests, chronic HCV cases, opioid prescriptions, as well as median income. In addition to that, we knew that we wanted our core outcome to be opioid-involved overdose mortality and wanted to run the vulnerability assessment against that core outcome. Robert, do you mind going to the next slide? Thank you so much. In addition to these pre-selected core indicators, we also wanted to be able to select from a list of additional covariates. In that list of variables that we were interested in included a rural, urban, county level variable, an opioid use disorder services proxy calculated as the number of services in the county divided by the total county population, as well as a large array of socioeconomic status and social determinants of health variables from the American Community Survey. And we ended up selecting these additional covariates by using a bivariate negative binomial model strategy, where we ran these covariates in tandem with the outcome of opioid-involved mortality and used a cutoff point of p is less than 0.2 to select our additional covariates. Robert, next slide. Thank you. This list here is our final list of our 13 selected core indicators, as well as our additional 8 selected covariates. Robert, do you mind pressing next just once? After running our negative binomial models, we did find that 6 indicators in particular were independently and significantly associated with opioid-related mortality at a level of p is less than 0.05. The top 4 here actually are 4 of our pre-selected core indicators, being emergency department visits, arrests, prescriptions, and chronic HCV. But in addition to those 4, we also had 2 social determinants of health variables that did show up as independently and significantly associated, being percentage of female-led households, as well as unemployment rate. Beneath those, there are also some additional socioeconomic measures such as Gini index, which is a measure of inequality, the level of high school diplomas, percentage of the population with disability, and Black population percentage. Robert, do you mind pressing next once more? In addition, we also found some negatively associated variables, including median income, which was one of our pre-selected core indicators, as well as our services proxy and percentage with internet access. Awesome. Next slide, Robert. Once we had gotten all of our data and selected our 13 indicators to use, we then used a regression-weighted quintile ranking approach to conduct and calculate our vulnerability scores. This method primarily is conducted in 2 steps, the first of which is to take quintile ranks of all of our indicators and all of our selected covariates. And what taking quintile ranks means is, for example, thinking about emergency department visits, we took the top 20% of counties with the highest level of emergency department visit rates and gave them a 5. And then we took the next 20% and gave them a 4, meaning that the bottom 20% was ranked a 1. We did this for all of our variables and then weighted these quintile ranks by the standardized regression coefficients that we just calculated from our negative binomial models. The equation for this is in the middle of the screen, and it is just saying that the overall vulnerability score is calculated as the sum of all these quintile ranks weighted by their standardized regression coefficients, meaning that counties with higher vulnerability scores were noted as higher and more vulnerable. Robert, next slide. One of the benefits of using this regression-weighted quintile ranking approach is it allowed us to account for the negatively associated variables, these 3 at the bottom, median income, our services proxy, as well as percentage with internet access. Since we are weighting by the beta, the second column here, it allowed for us to account for these negatively associated variables, meaning that the higher the quintile of these 3 variables, the lower the vulnerability score of the county. Robert, next slide. After we've done this, we began to initially and preliminarily look at our results. We did this by, again, using quintiles to split into 20% groups, and then left out the top 20%, the highest 19 counties, and identified them as the most vulnerable to opioid-related mortality. As we began to look at trends, Robert, do you mind pressing next once? Some apparent trends were immediately made obvious. These are that there seems to be a higher number of counties that were most vulnerable in East Central Indiana, Northwest Indiana, as well as Southeast Indiana. Another trend that we did note is that it seemed that the counties with higher population density seemed to be more vulnerable, being Marion in the center, as well as Lake and Vanderburg in the top left and the bottom left. Awesome. Next slide, Robert. Another thing we began to look at is we had initially tried to select for a rural versus urban county level variable, but it was not found to be significant at our cutoff point of p is less than 0.2. And we were curious as to why, because in some other state level vulnerability assessments, we did notice that rural versus urban did play a part in other states. To look at this, we in particular use the Purdue Rural Indiana classification system as opposed to a national classification system, because it included things such as local identity, a qualitative variable, which we preferred as it provided some local context to this variable. And then as we began to assess why, we began to note why this variable may not have been significant, because as we're looking at the top levels of vulnerability across the counties, we do see vulnerability across the continuum of rural to mixed to urban, with 8 urban counties, 6 mixed counties, and 5 rural counties being the top 19 most vulnerable. Robert, next slide. Our last step after determining county level vulnerability was begin to assess vulnerability in relation to where services were for opioid use disorder services, as well as naloxone providers, as well as the all-important syringe service programs. And we begin to assess this against vulnerability in this map on the right. However, as you can see on this map on the right, there's a lot going on. It seems that our population dense counties like Marion in the center seem to have way more points because this map doesn't take into account population size of the counties. It becomes really hard to assess what's actually going on. So in order to better assess and get more nuanced look at accessibility within the state, Robert, next slide, we used a method called two-step floating catchment area to do this. And two-step floating catchment area, otherwise known as two-step, is just a common spatial method to assess accessibility of healthcare services. We use two-step to assess accessibility of both opioid use disorder services as well as naloxone providers at the census tract level. We ended up not running one for syringe service programs due to the limited number of syringe services programs in the state. And to conduct our two-step analyses, we used the University of South Wales Floating Catchment Area 2 ArcGIS add-in tool to do all of it. Robert, next slide. Awesome. So I'm going to get a little bit into how we connected two-step and what two-step does. Funnily enough, two-step is conducted in, you guessed it, 2 steps, the first of which looks at providers and the second of which looks at population centroids or populations, or in our example, census tracts. The first step of two-step is to create drive time catchment areas for each provider. If you look at the graphic on the right, our providers are represented by the green triangles, and their catchment areas, or a drive time around them, is the green blob around all of our green triangle providers. In that first step, after you calculate each provider's catchment area, you then sum the total of the population within that catchment area. If we look at the provider, that green triangle in the top left, we can see that there's only one red dot representing populations within its catchment area. But if you look at the bottommost triangle, that provider, there are 2 populations, 2 red dots within its green catchment area, meaning that the provider to population ratio that we calculate for the bottommost triangle would be 1 divided by the sum of both populations of both census tracts within its catchment area. The second step is to do something very similar for population centroids, those red dots in the graphic on the right, and to create set distance catchment areas around them as well, which is represented by those blue circles in the graphic. Using the previously calculated provider to population ratios that we calculated in the first step for each provider, we then take each population centroid, look within its blue circle catchment area, and then sum together the total of all the provider to population ratios of all the providers, all the green triangles within the blue circle catchment areas. This calculates the accessibility score and allows us to determine what accessibility might be like at the census tract level. In particular, we preferred using this method as to a simple look at total number of services in the census tract divided by the population of the census tract, because it not only provided us more nuance of what providers or what populations providers might actually be able to see, but it also allowed us to provide nuance onto what populations might actually be going to certain providers. Using the bottom provider, that bottom green triangle as an example here, if we just used total services in the census tract divided by population, that bottom rightmost census tract would not have included that provider that's right on the border. But with two-step method, it allows us to include that within the population's catchment area and provide some more nuance to our assessment. Robert, next slide. Awesome. So after we had run our two-step analyses on opioid use disorder services and naloxone providers, we're able to look at some of our preliminary results in relation to the previously calculated vulnerability that we had done. Looking at our results, we noticed that among the 19 identified most vulnerable counties, only Fayette and Scott counties ranked within the highest quintile for all census tracts within the county for opioid use disorder services, and this was only apparent for Fayette when we looked at naloxone providers. In a very similar trend, 15 out of the 19 identified most vulnerable counties had at least one census tract within the bottom 20%, the lowest quintile, for opioid use disorder services accessibility, and 14 out of 19 had accessibility within the lowest quintile for naloxone providers, demonstrating that we were able to identify specific needs and gaps in services in the counties that we identified as most vulnerable. And now I'm going to turn it back to Robert to talk about how we compared to some of the previous vulnerability assessments, as well as some implications of our findings.
So now we have 3 assessments to look at. And so in the blue and gold shades are what I showed before. So that comparison. So now the red outlines are the counties identified by Jared and the rest of the Tufts team. So, we can see some overlap. 4 of the 5 counties that have been identified by both assessments before were also identified by this newer assessment. We also had quite a few counties identified that were not, especially in urban areas, Vanderburgh, Marion, Lake, Clark, for example. And then see some more clustering in this East Central area as well. So, yeah, some counties match 1, 2, none, 3, none at all. So it's not too surprising that there were some differences. That's not necessarily a bad thing. We know that each assessment was done at a different time period, with some different methodologies, some slightly different but related goals. So, we're not surprised that there wasn't a complete match. So what does it mean if a county matches in all 3 assessments? That means we definitely want to continue to pay attention to those areas, and more, down the line 2 or 1. For some of these new counties, this might think, hey, maybe we need to think about this in a different way. Maybe the situation is changing, and again, not that we don't pay attention to different parts of the state that weren't already identified. We talk about highest risk, but definitely every county faces some degree of risk. We know that opioid use takes place across the entire state. And again, these assessments are rather broad. Local knowledge is still the most important thing for how this gets used in the future. So before I move to limitations, also wanted to mention we do have a couple specific uses in mind for how we want to use the information collected in this assessment. Unfortunately, it's not far enough along for me to talk about it yet for this presentation, but we do definitely have a couple ideas in mind for what we want to do going forward, just not at a state where I could include those yet, but we're definitely looking at this and using it in some things that we're doing. So some limitations, COVID really delayed the research that started in 2019. We had a journal article published on this about 3 months ago now, but it just delayed us, and like the data that we were using was coming from like 2018 ACS. So there have been updates in the American Community Survey since then. Facilities can change from time to time. And also, as I mentioned, the pandemic has changed the landscape so much, and the increase of overdoses and deaths. We were using only publicly available data to make sure that anyone who wanted to look into this in more detail could go back to it and see what we were using. But this did limit us to a lot of the data only being available at the county level. And also we need to recognize that Hoosiers may be accessing treatment resources in other states, especially if they're along the state border. And that's something that we can't really account for in this method very easily.
Hey, Robert, thank you so much. I just wanted to go ahead and let you know that there's only 5 minutes left if people wanted to go ahead and ask any questions to the
Yeah.
amazing presenters.
And that was basically my last slide. I've just got acknowledgements, the team we worked with here, the resources I mentioned, and yeah, we're happy to take questions now.
At this time, nobody's provided any. I think you've been very thorough, and but we can wait a minute or two, see if anybody has any to ask. I did have a quick question about when you were looking at the countywide, especially the counties along the state lines between Ohio and Indiana, say. Was some of the data, like Dr. Weaver was saying earlier, influenced at all by adjacent state data that maybe was missing or,
Yeah.
kept awkwardly?
It could be. That's one of the limitations. We didn't do anything to incorporate that specifically. I guess I don't remember if we really looked into it, but yeah, I can especially see there. I mean, quite a lot of these counties identified are along the border with Kentucky or Ohio, or really all our neighboring states. There's a border there. What else was I going to say about that? So yeah, I mean, there are definitely facilities there. We don't always have as detailed information on those or the rates. Maybe there's potential for looking in that a different way in the future. And on the flip side, people can be coming from other states into Indiana for treatment. So there's that side to it too. And that can also be pushing the capacity that some of our facilities in bordering states also have. So that can go both ways.
Chris added that some of the trends are along interstate systems as well. So yeah, that's true. And maybe, like you said, that transportation issue is a factor as well.
Yeah, we've talked about that before. It's not really specifically incorporated in here, aside from when we've looked at vehicle access. But yeah, that's something we're aware of as well.
Any other
else I was gonna say, but I lost it.
Okay.
Jared, anything to add to that?
No, that was very thorough. Interstate lines being a focal point of vulnerability was definitely seen in other states when we ran other assessments as well. So it's a coherent thing to note.
Yeah. Oh, I remembered the other thing I was going to mention. The Van Handel study, that was the only national study of these three. We didn't have a map of it here, but they identified a lot of counties in Kentucky and West Virginia, Southern Ohio, I believe. So, kind of from this map, I'm imagining this area and down to the southeast, there's the highest concentration of counties were identified in that area. But I believe they identified at least one county of high vulnerability in 42 states, if I remember correctly. So some of these those might be only one or two, but there was a concentration, but also a lot of spread in some individual counties.
Well, I do not see any other questions. We are at just about 10 o'clock. I want to thank you both for coming and appreciate all the information and the hard work you've done and looking into this issue. Our next sessions will start in 15 minutes. So please tune in to whatever your next interests are.